like to acknowledge the sponsorship of today's presentation. As I mentioned a few minutes ago, I'm a program director with the National Center on Substance Abuse and Child Welfare. The National Center is implemented by the Center for Children and Family Futures and supported and funded by the Substance Abuse and Mental Health Services Administration and the Children's Bureau and the Administration on Children, Youth, and Families. Before I introduce today's presenters, I'd like to frame today's webinar a little bit for everyone who's joined us today. Today's presenters, as I mentioned, are with the ACOG, if you will, American College of Obstetrics and Gynecology, District 2 office in New York, or they're affiliated with. There's only one of our presenters who works for ACOG, and you see here the other presenters that are practitioners in their respective areas of practice. New York State is an in-depth technical assistance program site, if you will. We call it IDTA, and has been an IDTA site for a little over 2 years now. And today's presenters are engaged in that IDTA work in New York State. The lead agency for the in-depth technical assistance for New York State is the New York State Office of Alcoholism and Substance Abuse Services. And the members of today's presentation, today's panelists, are active participants and are members of the core team for that work is in-depth technical assistance. Before I get started, I would like to share with you an article that appeared in the New England Journal of Medicine back in February, and it's entitled "Caring for Miss L, Overcoming My Fear of Treating Opioid Use Disorder." And I think it frames part of the discussion today in the challenges associated with physicians and other healthcare practitioners in treating persons with opioid use disorders. And in this article, a primary care physician who wrote the article describes her experience with a long-term patient of hers who was in long-term recovery, who relapses on prescription opioids as a result of an injury, on how that patient asked her to treat her with buprenorphine. The physician describes that she wasn't a treating physician, not licensed to prescribe buprenorphine, but goes on to say that there were other reasons why, as a primary care physician, she did not want to take on treating patients with substance use disorders, and she describes being already overwhelmed and not wanting to take on patients with needs, quote, that I did not know how to meet. She refers that patient of hers to a colleague who is a treating physician with buprenorphine, and finds out that over a year later the patient died of an opioid overdose. And she describes kind of her personal anguish over that situation and making a decision to become a prescriber, earned her waiver to prescribe buprenorphine. And describes how she could not provide that care without the support of colleagues with expertise in addiction and social work, quickly grasping the pharmacology of buprenorphine therapy, but learning how to manage other aspects of addiction care, particularly for patients in early recovery, has been formidable. She goes on to talk about that kind of transition, if you will, from not wanting to treat patients with an opioid disorder to really changing her whole practice and her whole outlook and approach to patients with the disorder. And she finishes this article, which I felt was extremely powerful, by saying, and I quote, "Caring for these patients has become the most meaningful part of my practice. Providing some sense of normalcy for patients whose lives are roiled by overdose and estrangement is the most profound therapeutic intervention I've engaged in as a caregiver." And so with that, I would like to introduce the caregivers, if you will, and the practitioners who are presenting today's webinar. And so first up, if you will, Kathleen Dermody is a licensed midwife at SUNY Upstate Medical University Regional Perinatal Center with a doctorate in nursing practice at from Stony Brook University. Kathleen is the director of Centering Pregnancy Special Care at SUNY Upstate Perinatal Center in Onondaga County, New York, and plays an integral role in the ACOG District 2 Opioid Use Disorder and Pregnancy Task Force. Dr. David Gary is the Director of Maternal Fetal Medicine and the Professor of the Department of Obstetrics and Gynecology and Reproductive Medicine at Stony Brook University School of Medicine. Dr. Gary is the co-chair of the ACOG District 2 Opioid Use Disorder and Pregnancy Task Force and works with ACOG nationally and as a fetal alcohol spectrum disorder champion. Kelly Gilchrist is the Medical Education Manager for ACOG District 2 in New York and the lead staff on their Opioid Use Disorder and Pregnancy Initiative. And with that, I'll turn it over to Kathleen to begin our presentation. Kathleen?
Great, thank you very much, Ken. Advance the slide here. Oh. Slide going forward. Hi, thank you so much for listening. Opioid-related overdose deaths have more than quadrupled in the past 15 years. This is a public health emergency. The rates of heroin and prescription opioid-related overdose deaths continue to rise, especially in young women. We're going to look at some of the origins of this public health crisis and discuss an integrated, multidisciplinary approach to this problem. So let's begin by looking at prescribing practices. Can somebody advance my slide? Oh, there we go. Okay. So in 2012, providers, including myself, wrote 259 million prescriptions. All of us providers realize that some of this came from internal and external sources. In 2002, you may remember the Joint Commission changed how pain was managed, and that pain actually became the enemy that needed to be eradicated. And an interesting monograph on this can be obtained from Joint Commission's Pain and Standard Origins and Evolution. That was published in 2017. A very interesting article on how this whole scenario occurred. But what we have is enough opioids out there for each American to have essentially a bottle of pills, a 30-day supply. And we know from statistics that 1/3 of reproductive age women have filled a script for opioid in the past year. So that's a lot of opioids out there. Most take opioids as prescribed, and most opioids are used for chronic pain conditions. Some are used post-op, post-injury, post-ER visit. And you can see the graph on the right shows an interesting correlation between sales of opioids, which is your dotted line on top, deaths from opioid, and admissions to a treatment facility or a hospital regarding either an overdose or ingestion of opioids. The other thing to mention is that the prescribing practices can be misused. Misuse of pain relievers is probably the second most common cause of illicit drug use. And if you were to ask where do most of these, where is the supply of pain or opioids coming from, I think most people would think drug dealer or some internet source or something illicit or nefarious. But in fact, what we know from the National Survey on Drug Use and Health, which annually surveys about 70,000 people throughout the U.S., people are asked to identify where they obtain their opioids. And the most common source is that blue piece of the pie. That's the Friends and Family program. And of that supply, most of that source is from one prescriber. And I looked at this data thinking, well, the CDC changed their regulations. Certainly there has to be some a change in this graph. And in 2014, instead of it being 53%, it was 50.5. So it's not a significant amount of decrease in prescribing. So each of us need to look at what we are prescribing, the education and who we are prescribing for, and also talking to patients about what to do with any unused prescription. And I'll give a plug for Prescription Take-Back Day, which occurs nationally on 10/27. So all of you listening who have opioids unused in your medicine cabinet can take those prescriptions back to either pharmacy, some hospitals have them, and get them out of your home. Next slide. Oops, delay. There we go. So the impact of overdose deaths is significant. Even with all of our aggressive state action, last year in New York, over 3,000 persons died, male and female, from chronic drug abuse. This is a significant increase, and there seems to be no decrease in sight. The next slide shows a graph. This is really delayed here. There we go. The next slide shows the increasing rates of opioid-related deaths. And most people would, again, probably perceive that this is a New York City problem. But in fact, if you look at the state of New York has some excellent graphs. If you're interested in more detail, you can look by county. And by and far, this is a rural problem in New York State. We see significant increases in the North Country, up near the Canadian border, in the West, Chautauqua and Erie County. In our area, central New York, we have a significant increase in the rates of deaths and in the rates of neonatal abstinence syndrome, which for us in about 2010 to 2012 was the canary in the coal mine, leading us to increase our efforts.
Thank you, Kathleen. And thank you to Ken and the team at the National Center for the opportunity today to highlight our work here in New York. So before we go further into our clinical content, I just wanted to take a few moments to discuss our project efforts here in New York and how we came about developing our clinical content. And so, I don't know, are we advancing our slides? Yes, okay. So in 2017, with the support from the New York State Health Foundation, District 2 received funding for 2 years to educate women's healthcare providers about the comprehensive management of pregnant women with OUD, with the goal of increasing education and awareness on evidence-based guidelines for the care of pregnant women with OUD. And so we developed a multidisciplinary task force comprised of OBGYNs, pediatricians, neonatologists, family medicine, social workers, and various key partners from across the state, which I'll elaborate on a bit later in the slide deck. So Kathleen and Dr. Gary are a part of that task force that we developed. And as Ken noted from the article he read, you know, it definitely does take the additional support and the multidisciplinary task forces to manage and treat these patients. So why pregnant women? Well, pregnancy provides an important opportunity to identify and treat women with OUD, and it's optimal care of pregnant women with OUD, and it should be done using a multidisciplinary comprehensive care model, as we've discussed, with early universal screening, brief intervention, and referral to treatment of pregnant women with OUD to improve maternal and infant outcomes. So a large part of our efforts began here in April 2017 when we held a statewide educational summit in Syracuse, New York, to provide multidisciplinary task force members with an opportunity to network and learn from their colleagues and develop key recommendations and solutions to improve the management of OUD in pregnancy. So at that summit, we had approximately 50 participants in attendance and a panel of experts who manage the various aspects of women's care, such as the OBGYNs, pediatricians, social worker, family medicine, and we even had someone on our panel from the justice system. So following the panel, we had attendees break out into groups to discuss the challenges presented during the panel and then develop some solutions. And then as a result of our summit, a white paper was developed to provide actionable strategies to effectively manage OUD in pregnancy. So the slide's a little blurry, but you'll see here some summary of the key recommendations provided within that white paper. The white paper summary was public health, policy, and clinical recommendations, and this slide just highlights those key areas. So change perception of OUD through the use of a common language, which we'll get into in a little bit, which is provided within our bundle, so addressing the stigma associated with OUD and pregnancy. Developing and offering a multifaceted education and implementation tools to better assist women's healthcare providers, hence our bundle we're presenting today. And then creating better engagement and communication among providers within the continuum of care. So ensuring providers are aware of the various resources within their region available to women and their families, and then how to access and link patients to those resources. And then enhancing patient and family engagement, so including or being sure to include patient and families when developing a care plan. So the next two slides just walk through a little more detail as far as those recommendations are concerned. So with changing the perception of opioid use disorder for healthcare providers, it's the need of tools and education for all staff and the use of harm reduction language, which we'll speak to a little bit later on. And then reframing for the public health community, reframing opioid use disorder as a chronic disease, so bringing awareness to the public. And then developing and offering education and implementation tools, again, for the healthcare perspective, having mentorship folks for the buprenorphine training. And I will say, since the development of this paper, we have learned that there are some buprenorphine mentoring programs now offered in different regions of the state. So it's been really helpful for those providers who, receive their waiver training, but may not have initiated yet. So having someone to go to help with that first initiation would be really valuable. And then for the public health, expanding a hotline to facilitate mentorship. So similar to the New York State HIV hotline, having something for opioid use disorder. And then for this slide, creating better engagement and communication across service areas. So for the healthcare providers, developing patient care plans with teams of providers. So again, just emphasizing that multidisciplinary team approach for care. And then for public health, educating local jails to facilitate access to MAT. So early on in this process, we definitely learned that some counties are not following the appropriate guidelines for pregnant women with OUD, and having them withdraw from their MAT. So just bringing awareness and education is definitely needed in several counties. And then enhancing patient and family engagement. Again, we found, you'll see throughout our bundle, we have several resources for providers and FAQs that they can give to their patients and their families. And then for the public health around new laws regarding reporting for child abuse and the CAPTA laws. So we are, as Ken noted, very engaged here with our partners at OASIS through the IDTA program to learn what the various resources are available and sharing those with our providers through this bundle, and ensuring that we have consistent messaging. So I know many of you can probably relate when it comes to the various initiatives and efforts around this topic area within your own states on how to not overlap or duplicate efforts. So I will say that it's very key to have those collaborative relationships and partnerships, and it has proved very successful here in New York to be connected to all the different teams working on OUD and pregnancy. And it's critical to understand how those initiatives engage with each other, complement and supplement one another. So this slide just shows you the various partners we're working with on the national and state level. And I just wanted to highlight a few of those, and it sort of frames the next set of slides. So we are engaged with our national ACOG through the Alliance for Innovation on Maternal Health and the Maternal Opioid Use Disorder Patient Safety Bundle that was developed through AIM. And for just way of background, for folks who aren't familiar, AIM is a national data-driven maternal safety and quality improvement initiative, and it's based on proven implementation approaches to improving maternal safety and outcomes. And so AIM has 20 states engaged currently. I think they're working on 21 right now. And in addition to focusing on opioids, they also focus on the 3 leading causes of maternal death for OB hemorrhage, hypertension in pregnancy, and venous thromboembolism. And so through the AIM initiative, what we've done here in New York is taken the AIM bundle, it's a 2-page document that you'll see in the coming slides, on maternal opioid, and expanded upon that bundle to provide implementation tools and resources specific to New York State. And so through AIM and on the state level, in partnership with our New York State Department of Health, New York State Perinatal Quality Collaborative, we are rolling out some OUD and NAS education to 17 pilot hospital sites at various levels of care across the state before rolling out our initiative statewide, and conducting in-person learning sessions as well as coaching calls for those teams. And so we've already completed one in-person learning session and are working with the teams at those pilot hospitals to implement the educational efforts here. They will be doing some data collection, and with our clinical advisors, which Kathleen and Dr. Gary are on that task force, providing some coaching call insight for those folks. And so we are also working with the New York State AIDS Institute, Office of Drug User Help. They're doing a lot with buprenorphine waiver trainings across the state. So we're being engaged in those efforts and pushing that information out to our membership. So I can't stress enough the importance of the collaborative partnerships and the importance of those relationships. And I am grateful that we have folks on our task force and teams such as Kathleen and Dr. Gary. So with that, I'll turn it back over to Kathleen.
Thank you, Kelly. So in front of you, if we can go back here, to the patient safety bundle. So the patient safety bundle essentially outlines the approaches that we're going to take and identifies what we feel are important needs for addressing patient and family, the healthcare system, and the individual providers. So there's so much that's in this. I want to highlight a few of the most important and bundle pieces that we have worked on. Stigma and discrimination, we'll talk about. Engaging the patient and family, and again, as Kelly said, using a multidisciplinary approach, peer resources, hospital, home, family, community, and really doing that care coordination well so there is not overlap or waste of services. Again, we've done this intentionally using a multidisciplinary group so that all voices were heard, not only in the planning, but assessing the needs of the family as a whole. I'm trying to, okay, there we go. So beginning by just defining our problem. So physical opioid dependence is really it's a physiologic adaptation to the body as a result of being exposed to an opioid. It can occur in all of us. It occurs by taking the substance and then the development of withdrawal symptoms when those opioids are discontinued. It may occur if one is on an opioid and is administered a medication such as naloxone or Talwin, Stadol, Nubain, which could essentially reverse one of the opioids. This is a normal and expected response to continued opioid therapy. We understand that this is going to occur. But it can occur very quickly in some folks, and it depends on multifactorial. But physical dependence does not mean that the patient is addicted, and that's a really important concept. So addiction is essentially a chronic disease of the brain. It's a brain disease. It occurs because of feedback with reward, motivation, memory, and related circuitry within the brain. And dysfunction in these circuits leads to that characteristic biological, psychological, social, and spiritual manifestation. So this is not a moral failing. This is a progress of a disease in the brain. And it's so worded like that when we get to the next slide to show the different causes of addiction. But like any other chronic disease, it involves cycles of relapse and remission. And without intervention, the disease progresses and can result in disability and death. This slide is is critical in understanding and helping families to understand that addiction is a chronic and relapsing condition. It's sometimes difficult for even other professionals to understand that, well, she was in treatment, but now she's off treatment again. And the whole understanding is that comparing this between other types of chronic medical illnesses, there are many similarities. For instance, the rate of relapse between addiction and these other conditions are very similar, 40 to 60 in drug addiction, type 2 diabetes, 30 to 50, hypertension, 50 to 70, as with asthma, people not taking their inhalers, people not taking their medications. I think when I'm talking with families and trying to explain the importance of medication-assisted therapy, using the correlation of care of the person with diabetes. So that person may need medical management, and it may be required for a lifetime. They may lose weight, dietary changes, things improve in their life, but their glycemic control will be dependent to a certain extent on the use of either metformin or other glycemic agents. So this puts the emphasis on physiology, that this altered physiology requires medication treatment to avoid complications. And it helps the patient and family understand that this can be a lifelong condition. So the different substances, this list is not restrictive, however. There are multiple other substances and habits and things that we can be addicted to. And the key here is that this occurs when recurrent use or practice of the substance causes functionally significant impairment. The person does not meet their responsibilities. Their relationships start falling apart. They fail at school. They don't come to work. They are unable to take care of their children. So when substance or alcohol, stimulants, hallucinogenics, tobacco, marijuana, all of these can lead to substance use disorders. Opioid use disorder is, again, it's a chronic but treatable brain disease. As we just talked about, it may require medication for many, many years or a lifetime. And combining medications such as buprenorphine or methadone with comprehensive care, these women and men are able to live very healthy lives, more in control. They're able to take care of their children, go to work, meet their responsibilities at home, and we'll go through the criteria in the next slide. But the treatment with buprenorphine and or methadone is recommended in pregnancy. We do not recommend withdrawal, even though medically supervised, because the studies just aren't there to show success, and the high relapse rates actually lead to worse outcomes or death. So we, right now, ACOG does not support medically induced withdrawal. So the DSM criteria is pretty clear, whether it's mild, moderate, or severe. These criteria include taking the opioid in larger amounts, wanting to cut down but can't. These persons spend a lot of time trying to obtain the opioid, and this is one of the things when you talk to them once in treatment, they will recall how much time and energy it took them to really be obtaining their drug. Continued use despite persistent, their family is not supportive, they're losing their family, they're just unable to meet those needs. And the listing here is similar to what we've just talked about. All right, so screening and testing, Dr. Gary is going to talk about.
Good afternoon. So when we look at screening and testing and trying to determine exposure of substances that our patients may be bringing with them, there's testing, and testing is typically the urine toxicology. not necessarily blood tests, but urine toxicology. And then screening, when we talk about screening, we're talking about a verbal test. Using a tool, whether you're using the 4 Ps, using the NIDA Quick Check as just 2 examples of screening tools, but to utilize a screening tool when patients are coming for prenatal care should become a universal practice across the country. Let's see if I can make this advance. Okay. Urine toxicology, when you're looking at this, you have to understand that, 1, patient consent is recommended. In New York, we do obtain patient consent. Other states may have different laws surrounding this. So it's just recommended that you figure out what is going on in your state with respect to toxicology and its use in taking care of pregnant women. But understand there are false positives and false negatives. When I say false positives, there are some interactions with drugs, et cetera, and other things that can cause the test to be positive. And then there are false negatives in the fact that there's simply substances such as synthetic opioids that need some special testing. And on a general urine toxicology will come out negative. All our testing here, we send out confirmatory tests before officially deeming the person positive. So we have a check system in place when using urine toxicology. All right. I don't know, the delay, little delay, sorry about that. So in screening, we use the system called SBIRT, or Universal Screening Brief Intervention and Referral for Treatment. Utilizing this has been shown to improve pregnancy outcomes. It can improve pregnancy outcomes with respect to alcohol, other substances, opioids, and of course it is administered by either a physician, a nurse practitioner, a PA. It can be administered by your medical assistant, who is trained to utilize the SBIRT system. In your offices, I suggest that you figure out the best way to, or the best person to speak to the patient and provide the brief screen. Now, what happens in the office and what's real life? When do we do this screening? How much time does it take? When do we have time? We have a lot of things to cover in taking care of pregnant women. Especially in the first visit, you have evaluation of their history, evaluation of their home environment, evaluation of their genetic history, evaluation of what they want to do in the pregnancy with respect to aneuploidy screening. So there's a lot of things that we are looking after. And so recommend that at least screening them on initially, and then again sometime in the pregnancy to rescreen them. And where to screen has also become a difficulty from the practical point of view. You can't do it out in the open in your office waiting area. Patients may or may not divulge information depending on who is asking the question. So all of this becomes a problem. Which tool? As I mentioned, there were some tools before. There are several out there. You just have to pick one. Which tool is best? I guess is how comfortable you are with the tool is probably the best answer. I use 4 Ps. Other people use different screening tools. And then, of course, the management of when somebody's result is positive. That is what scares practitioners. Nobody actually wants to hear the positive, because that means now you have to do something. And so when taking care of women during pregnancy, you have to prepare yourself for, well, what do I do? Don't stop short in your thinking process. Think out the algorithm of, all right, if she screens positive for opioid use, this is how I want to approach it. Now, from the patient side, as I said, they may be fearful of saying anything about opioid use because that's going to create a problem for them. And it may create a problem in their minds of, am I going to be able to keep my baby? The other big issue with patients is they don't want their family members to know. They may not even want their significant other or father of the baby to know. And lastly, relatively new, and I'm sure most people across the country have the same issues, is trying to incorporate the EMR into this. The medical record, electronic medical record, has become useful for some things, but then difficult to use for others. And you just have to approach it by figuring out with your IT department and figuring out from maybe others' suggestions how to put a tool into the system and then begin to utilize the tool. Now, enhancing the patient and family engagement. So you have to look at pregnancy as an opportunity. It's a time when women are motivated, and this is a time when you can make a difference in a woman's life. Engaging the family or significant other, I believe, is important because the support system for maintaining healthy lifestyles is extremely important. I've told women basically they need to tell if they're young women, their mom, or they need to tell their boyfriend or spouse, or they just need to tell everyone in their family what's going on and why they are where they are, with the understanding that your support system will do exactly that. They will forgive what happened, that you have shifted your life to an unhealthy behavior. You didn't want to go there, and they will support you in taking care of you. The questions that women ask all the time: am I hurting my baby? So, have I hurt my baby already? Am I hurting my baby? Is the medication that you're going to put me on going to be harmful to the baby? And these are answers that need to be able to be answered to the patient for reassurance. The other large question, of course, is my baby going to be taken from me? And I will just answer that I tell the patients, if you adhere to prenatal care visits, you adhere to your medication and your visits with counselors, and you screen negative, or you have urine toxicology negative on admission to labor and delivery, when you do deliver the baby, the social workers are going to visit with you. They're going to evaluate you and making sure that your home environment is safe, and that the Child Protective Services, or CPS, will not be involved necessarily with your case. Now, should something go sideways in all of that, then Child Protective Services may become involved. And if they do, they're simply looking after the child. They're making sure that the child will be in a safe environment. And so you have to understand that it's not personal. It's not saying you're a bad mother. It's simply the system is trying to protect the child. And your job as the mother-to-be is to put yourself on a good, healthy lifestyle and follow the program. We try to advance there. So one of the things with reducing stigma is probably in medicine is a relatively, we'll say, hot topic right now because it involves all forms of medicine, whether you're taking care of diabetics, hypertensives, asthmatics, or patients with opioid use disorder. And the way the best example I look at it is when someone talks to me, well, she's a heroin addict, the actual answer is she has opioid use disorder. She did not plan on doing this. She didn't wake up one day and say, let me use heroin. There was a process that got her to where she is. It is a known disorder, and we should refer to it in a more medical manner so that patients can feel more respect and have a sort of a confidence that in following the program, she will become a better person and a healthier life. Now there's some words here, if I can get to the next. There, words matter. So these, this is a words that were actually used this for politicians when speaking about opioid use disorder. And when we put together this bundle, we thought these were just some good examples to put into things. As you've heard me say, healthy or unhealthy behavior. I've been using that for a while now. I try to stay away from clean or dirty, just as the second bullet point says. It's just the slow, sorry for, although down at the bottom it says crack baby, and that is an old term. It applies similar to this. This is not an opioid baby. We should really watch our language and remember that this is trying to be respectful. You don't get very far in taking care of patients if you're referred to them as, if they're obese, if you refer to them as fat, it's not going to work well as a provider. So the same thing is true with opioid use disorder. So looking at our plan of safe care and developing the network, utilizing the people that are available, the social workers, case managers, legal services. Locally, you need to understand who the individuals are, whether it's the inpatient or the outpatient, and then to organize that. At our institution, myself as an obstetrician, as well as 3 other obstetricians, coupled with pediatrics, there's 2 members from there, and social work. We meet on a regular basis and we discuss what's going on. In addition, we involve anesthesia, not more on by individual cases in making sure they have are able to provide the pain relief, because pain is a big problem that patients complain of. So anesthesia gets involved on a case by If anyone can advance the slide, go ahead. Okay, so again, back to the plan of safe care, the home environment, is it appropriate? What services are available? The part about post-delivery care at the bottom, I want to say from a personal point of view, I have taken this very seriously, because what I've seen is patients doing well through pregnancy, doing well through labor and delivery process, and then in the first 2 to 3 weeks after delivery, returning to some unhealthy behavior. We actually have 3 maternal deaths here in the last 18 months. All 3 of those were women who returned to heroin use following delivery while the child was actually still here in the hospital on observation. So I personally have tried to reduce any kind of barriers that I can in trying to keep women on medication-assisted therapy and making sure they're receiving counseling immediately following delivery. So looking at the professional education and teaching your people in any of your units, whether you are inpatient or outpatient, is important. I now have met with the nurses in labor and delivery. Our office, we're having a meeting about this so that they understand the language of opioid use disorder, and that they understand why we're doing this, and that how we can make a difference. The medication-assisted treatment involves either methadone or buprenorphine. Some centers around the state or country have the availability of both medications, while others only have certain choices, maybe only methadone or only buprenorphine. Be able to understand that women may do well on one medication and not another is something to deal with medically, but at least placing these patients on the medication is important. But when you run across women who say, look, I don't want to help myself, I don't want to do that, you as a provider need to be able to accept the fact that some women are not ready for this. And that's all part of the SBIRT and measuring and motivational interviewing, measuring readiness for change. And if a person is not ready for change, you need to just come back to them again, maybe a little bit later, and trying to get them to change behaviors. When I look at harm reduction, very important, and I will just give you some facts just right now for the state of New York for 2017. This is the state of New York excluding New York City. There were naloxone, which is also known as Narcan, administered by EMS 8,000 times in the year 2017, and then also administered by law enforcement another 1,500 times. So the use of naloxone is very important, making sure that patients have accessibility to naloxone, whether it's for themselves or one of their friends, but at least that be conscious of that and to be able to give out prescriptions for naloxone. Move on. So again, clearly defining what you're doing as far as screening and testing. And there's both the inpatient and the outpatient version of that. So when you look at a hospital, what are you going to screen with? Who is going to do the screening for the hospital? And when you're in the outpatient, who is going to screen? And then how are you dealing with the screening in your office? Very important to make sure that that's ironed out and that the staff understands your practice. And when we look at the different types of practices, there we go. Look at the different types of practices. Really, there's three bullets across the middle, 3 boxes across the middle. Those 3 boxes really represent the 3 types of obstetric practices. All the way to the left, which is the full range, which means you provide prenatal care and medication-assisted treatment in the same location. The middle box, which you provide prenatal care, but refer or co-manage the patient for medication-assisted treatment. And lastly, is you refer all the patients that have opioid use disorder to someone else who could care for them. So your practice just has to decide what type of practice you want to be. Here in Eastern Long Island, I can tell you that I can pretty much tell you what practices do what, and they make it work for themselves, meaning that when a patient is identified with opioid use disorder, that they are very comfortable in referring the patient. And my practice is on the full range of prenatal care, so they will refer the patient over to us. And it's relatively seamless, and the patient does not seem, does not get upset, does not feel that she's discriminated in any way, and it's very professionally done. A trauma-informed care. Understanding violence and its ramifications and some of the underlying why women are where they are in their lives. How did they get to this point? So making sure that you understand what is trauma-informed care. U.S. Preventative Services Task Force yesterday released the guideline that all women should be screened, all women of reproductive age should be screened for intimate partner violence. I think that's a very big step. And again, we're going to have to incorporate that into our practices to screen all women. I was listening to a talk today about this. It's not an easy topic to bring up. Women are often either surprised that you bring the questions up about intimate partner violence, or they are scared to answer. But again, it goes back to assessment for readiness. When they're ready to answer, they will be ready and it's our job to screen. And I'll turn the presentation back over to Kathleen.
Okay. Thank you. So this section discusses essentially how we're going to coordinate all of the things that we're proposing are critical for your practice, as have just been discussed. And again, excuse the delay. So establishing specific intrapartum, prenatal, postpartum pathways for women with opioid use disorder requires the multidisciplinary approach. I think you've heard this term multiple times. So you need to assure that you can get the entire team on board in making the plan. So again, the SAMHSA provider tools, the collaborative approach, this resource is available online, and it really can be beneficial to helping your organization not only develop like a steering committee, get the core team, people to facilitate, to educate, and you're looking for the resources. What are the resources that you can get from your community? Who's available, such as Dr. Gary? He's on staff. Let's use him to do an educational session for other providers on the dosing and the application of buprenorphine in practices. You're looking for gaps in your care. Where are people falling through the cracks? And also barriers. What are the difficulties that women are experiencing in obtaining care? And if you ask them, they will tell you. So this is where you need to involve not only staff, but you actually need to have that conversation with women. And in my experience, transportation is a huge barrier for these women. Often they don't have cars. They may have lost their license. They are going to groups. They're going to counseling. They have a lot of meetings. So trying to coordinate this multi-system approach and get an approach that best serves the need for women and their families, not necessarily your clinic or clinic hours. And a good example of that is the MOMS coordination model. There's other examples with Dartmouth-Hitchcock model. So these are out there, and you can. We have them available in the ACOG packet as well. Okay, so did I just miss that? Let's see. Treatment services. Oh, there we go. Coordination. Thank you. So establishing that care coordination is really important. Making sure that the treatment programs are available, and they may need to be available immediately. So a woman coming into either the ER or to your office may be actively using heroin, and it's important for you or your staff to have developed these relationships. If you don't personally prescribe buprenorphine or you do not have access to methadone clinic, you know where you can get that person in. Because often if you let her go home and just wait for the next day, she may die. So this is really critical to get this care coordination out there, to make those relationships. And, the advanced planning for the treatment of pregnant women with opioid use disorder, you want things to assess safe care for mothers and their newborns. And this can help prevent that unexpected crisis at the time of delivery. There should be no surprises when the woman hits labor and delivery. As Dr. Gary has alluded to, educating the patient, letting her know, a lot of this is antepartum education. Those questions that the mom asks, if she doesn't, you address those antepartum so that if there are gaps in what she needs or barriers, i.e. The slide he had with the car seat, you can link her to those resources so that she has every opportunity to develop her own plan of safe care for her and her family. I'm trying to advance that slide. Thank you. So treatment services, there may or may not be treatment services available to you in an area where I just provide some education via ACOG. There's only one treatment service in that whole county for women. We're in central New York, and we have some women driving 2 to 3 hours to obtain treatment. Even though there may be a local buprenorphine provider, many obstetricians or midwives may not feel that this is the type of patient that they want to take care of. So making those links and letting your services be known so that there can be coordination of services. In Onondaga County, this isn't part of the slide deck, but we developed a county Onondaga County task force from 2013 to 2014, and currently 50 local agencies are members, and you can see that website at ongov.net, and it's titled Combat Opioid Addiction. And this is a community effort that responded, again, to that increasing rate of neonatal abstinence syndrome back in 2012. And there are six committees who participate in this. One on harm reduction, another on prevention and education. Law enforcement is involved, a family support and navigation group, mental health and substance abuse providers, the medical providers, and a new committee called Bridge Providers. One thing we realized, persons like myself, I'm in a clinic where there are no other buprenorphine providers, and we're unable to do that induction here. So getting that patient into a bridge provider who can start that patient on buprenorphine and then turn that patient over to you for ongoing care was found to be, again, it was another barrier, and we addressed it. So that's an ongoing committee. Next slide. Can somebody advance the slides there? One of the most important parts of this piece, and Dr. Gary, I'm so glad that you addressed this, is that postpartum piece. We know that many of these pregnancies are unplanned, and in a recent study, which is outlined here, 74% of women had no contraceptive method. At discharge, 7.4%, only 7.4%. That's a very low dose or very low rate, received any highly effective method. These methods are easy to use in the labor and delivery suite. IUDs can be placed immediately postpartum. Nexplanon can be placed. They're reimbursed. There should be no reason why a woman in her postpartum phase is not appropriately counseled and treated with a long-acting reversible contraception. Screening for depression, as we've said, depression runs quite parallel in this population as with others, but these women have a particular need for mental health care, and so your site should have readily accessible referral and treatment for mental health care extending into the community. The next bullet point is so significant. We had recently in our newspaper quite an extended story by parents of their daughters' experience 2 years after birth, aside from what Dr. Gary talked about in his community. So postpartum death does occur to women. That incentive to be good, to adhere to treatment, sometimes can be overweighed by the social and desires to use substances and relapse, as we've talked about. Women relapse. So we need to be there, possibly changing the way we do prenatal care, extending reimbursement for women to receive extended and comprehensive care throughout that first year. And just speaking of the additional needs for women, women do much better in women-centered treatment services. Dr. Gary brought up the idea of trauma-informed care, and this comes from the knowledge that many of these women have been abused sexually, physically, mentally in the past, and sometimes having males in the group may be distracting and certainly not productive to progress. So women-centered services may decrease the barriers to treatment, and they do help women engage. Fathers can be, so we have a centering group. We have fathers or significant others come in. They listen to the fetal heart. They're part of that assessment, but they leave when we come together, when we circle up. So there are ways to involve fathers, but certainly in treatment, the women-centered treatments are preferred. Next slide. I think the next slide, Kelly, is you.
Yep.
Just, okay.
Yeah.
I know, delay.
Ready. I'm just trying to advance, but delay here. So just quickly, in the interest of time, I know we do want to save some time for Q&A here, so we're almost done, but just a few ongoing and upcoming activities. We do continue to offer the grand rounds for this readiness bundle that Dr. Gary and Kathleen just walked through. So as requests come in, it's another way to reach a broader audience, and as well as these webinar offerings. And then we are working on a phase 2 response bundle, which is nearly completed. We hope to have that up on our site by the end of the year, which focuses on pain management strategies. We'll have some case vignettes in there, care coordination and linkages, as well as the postpartum care aspect. So look for that soon. And then we are as well working on some expert video vignettes in partnership with our New York State OASIS team specific to OUD and pregnancy. So again, we hope to have those probably by the new year. So look for those as well. And we continue our collaborative efforts here in New York in partnership with our Department of Health through the AIM Collaborative through our monthly coaching calls. And then turn it over to Dr. Gary for our conclusion. This is just a quick where you can find the resources that were presented today at our ACOG New York website, ACOG NY. This is what the home screen looks like, and our Managing Opioid Use Disorder project.
And
Dr.
in
Gary?
conclusion, so screening for substance use should be part of obstetric care. It should be universal, and that screening is a verbal tool. That we need to change our language to reduce stigma. We need to change that language, whether it's in the office or whether it's in the labor and delivery units or wherever you're encountering the patients. It's specific to have plans for both prenatal care, intrapartum care, and postpartum care for these women with opioid use disorder, because it is a special population, and that resources do exist. To look at the resources in your own region and sort of put that together, and also that ACOG, at least for the state of New York, has put together resources as well as some national resources. I'd like to thank you all for listening today on behalf of the American College of OBGYN. Your time is much appreciated. Thank you.
Thank you, Dr. Gary, and thank you, Kathleen and Kelly, for really great and thorough presentation, comprehensive. My background is in substance use disorder treatment, and I remember in managing residential program that oftentimes substance use disorder treatment was a portal for women accessing health care, that it became an entryway that, as you mentioned, often don't get prenatal care. We found that we had to make those connections to primary health care, and in many cases to prenatal care as well. In the presentation today really speaks to the importance of healthcare practitioners, particularly specifically OBGYN providers, and doing the opposite in screening and providing access and linkages to community-based services, to SUD treatment, including medication-assisted treatment, and the importance of getting more upstream than waiting for patients to either come into the treatment agency or, in some cases, be involved in child welfare agency, but the importance of getting more upstream and address potential substance misuse, substance use disorder issues during pregnancy to improve birth outcomes. Under the programs that we operate under the National Center, we're working with many sites that are trying to address this issue, implementation of plans of safe care under the CARA amendments to the Comprehensive Child Abuse Prevention and Treatment Act. And they've all, even though that a major focus of that work is in developing plans of safe care, and as the statute indicates that according to the statute kicks in at birth, they've all essentially committed to addressing these issues and developing plans of safe care during pregnancy, and the importance of getting more upstream in the sense of prevention, in the sense of integration and linkages between prenatal maternal health care and for those that are indicated that need it, community-based substance use disorder treatment. So, Doctor, we have a couple of questions. And so, Dr. Gary, we sometimes hear that screening and testing for substance use disorders drives women away from prenatal care. How would you respond to a practitioner who says that that's the reason that they don't screen and oppose screening in their practice?
I agree that universal testing, doing urine toxicology or blood and urine toxicology on all patients does drive them away. So I agree with that. And but however, verbal screening does not. And I think that screening is a very, we'll say, positive way to find out what is actually going on in a woman's life. You're screening for substance use disorders. We also screen for depression. You just heard me say something about intimate partner violence. So we need to sort of incorporate all of this into the screening process in a conversation type manner, not a yes, no. Do you drink? No. That we know that doesn't work. So do you use heroin? No. So it has to be a conversation. It has to be utilizing questions and developing a relationship with the patient. She has to understand that you are trying to help her, that you're trying to make her life a more healthy life, and that she is trying to help her child, that child to be, I should say, have a happy, healthy life too. And as I said before, women are very, very motivated in pregnancy. If you look at tobacco, if you go back years and look at tobacco and how tobacco cessation worked, it was extremely effective in pregnant women. So I'll stop there.
Great. Really, what you described, Dr. Gary, is an engagement. Is using screening in the context of patient practitioner, patient physician engagement in that conversation, as opposed to taking out a tool and completing a tool, and implementing that within the context of that conversation and within the context of effective engagement.
Right. I think it's using a tool. You have to be familiar with the tool, getting through the tool, but in not such a rigid manner. And if you use sort of motivational interviewing type techniques too, you're making it a conversation. So that's how I look at it.
Thank you. Kelly, in our work at the National Center, a lot of our core work has historically been centered around the interagency or cross-system collaboration between child welfare agency, substance use disorder treatment agencies, and the court system. Under under CAPTA, under developing plans of safe care, and many of the sites with whom we work recently, particularly in the last couple of years, are often challenged with engaging healthcare practitioners. That includes neonatologists and hospitals in terms of what happens at birth, but it certainly includes community-based practitioners, as we're speaking today, such as OBGYNs. And New York has been blessed, and we certainly have experience of that with the work, our IDTA work with you all in New York, having an ACOG District 2. But if the state doesn't have a state office that is part of a team, if you will, of a collaborative team to strengthen these linkages and services for families affected by substance use disorders, what would you suggest in terms of strategies for getting local OBs involved in developing plans of safe care for pregnant women, and part of that, and a big part of that, in terms of the linkages and the coordination with substance use disorder treatment and medication-assisted treatment?
So Kathleen and Dr. Gary, feel free to chime in when I'm done. You may have some ideas as well on the hospital level, but I would just say, working with your hospital teams and the resources you have, reaching out to your social workers and your teams within the hospital to learn what those resources are available to you, and then sort of, developing your own process. Dr. Gary has a great moms program at his facility, and Kathleen has the centering program at her facility. So coming up with a model or a plan that works best for you in your specific region. But really just learning and reaching out to the folks that can help you devise those plans and come up with what works best in your area. Doing grand rounds is another great way to sort of reach the providers at the local level and in private practice. So, educating your providers that way is also helpful.
Hi, this is Kathleen, and I think adding that the OB provider, be it NP, MD, CNM, they know that patient the most of anyone. So it's really important to have that communication with the social worker, with the nurse, with whoever's on that care team at the time the patient enters the hospital. So Dr. Gary gave that example of doing basically patient care conferences and evaluations. And I think also letting patients know ahead of time that this is it's an added incentive for them in care. One of the things I found interesting at that recent grand rounds is that patients or providers were not clear on what has to be reported, and I think now there's more clear documentation, and I believe it is in the ACOG bundle of what is reportable, what is not. What are the circumstances where someone would most likely get a referral and a knock on the door from CPS. So I think being really clear with patients and nurses and other providers about what are the things that really light up the switchboard in terms of risk factors. We're trying to protect the mom and the family.
Thanks, Kathleen and Kelly. Another question, you mentioned in your presentation today the implementation, the use of SBIRT, screening, brief intervention, referral, and treatment. And the SBIRT model out of SAMHSA was originally developed, I think, for application in healthcare settings, if you will, in the context of delivering healthcare to better identify and screen patients for potential substance use disorder and to make those linkages. I know New York's linkages to treatment. New York's had a pretty aggressive approach to implementing SBIRT throughout the state. Can you talk a little bit more about your experience with it or some of the implementation challenges as well as successes in implementing SBIRT, or maybe Dr. Gary, how that's enhanced your practice and how it's used?
Sure. I think the screening, first of all, is obstetricians and all providers that take care of pregnant women are very familiar with various screening. We do screening for aneuploidy, we do pap smears, so we have all kinds of screening that we do. We're screening for postpartum depression, so we're fairly good at it. So I have to say the screening component, hopefully everyone can address opioid use disorder, substance use disorder, and place that as part of how they take care of their pregnant women. So the brief intervention, this is where the person says, or you identify them as positive, and now you're a provider and you're shaking in your boots or whatever it may be, because now you have to do something. And that something can be something as simple as education, or it could be referral for treatment, the end of the S-BERT. So it really depends on what degree the patient in your evaluation. I used cocaine once during pregnancy. I mean, I'm not going to refer that patient for long-term therapy. I think what would happen would be a conversation about the we'll say cons of the use of cocaine in pregnancy, and just discuss how she may avoid you doing that again, versus somebody who needs, I need that is withdrawing in front of me, and I need to either refer for inpatient treatment or start, depending on because I also do outpatient initiation for we'll say opioid, because it's not withdrawal management, it's opioid switch. We're switching one opioid for the other. So for maintenance assisted therapy and starting therapy, I do that as an outpatient also with pregnant women, because they just refuse to go inpatient. So it depends on that degree of what kind of response as to, and have I found that to be useful? For me, it's become it's sort of practice. And I think for our entire OB practice, I think we're all looking at this in the same way. The referral from another person in my practice might be to me, or it might be to another person in my group that also does the same as I do. So it just depends, where it is. For other practices in the area, they may refer to us. They may refer to a medication-assisted treatment program and counseling, and then have the patient, as I said, the three types of practices that you could have.
Thank you for that. All right. We're going to conclude today's webinar. You see how you can contact us at the National Center, and me in particular, at Children and Family Futures and National Center on Substance Abuse and Child Welfare. And we're going to, if we could go back to the ACOG District 2 slide and give everyone another glance at any questions that participants on today's webinar may have for Kelly, and Kelly can be the portal as well as I can be the portal for questions that may come up to Dr. Gary or to Kathleen. If we could go back, Melissa, to that. That's the one. Perfect. Thank you. Yeah, there you go. Thank you. Thanks for your help. So again, if you have questions about any of the work that ACOG District 2 is doing, doing extensive provider education. They've been an integral partner in the work that New York State has undertaken under the in-depth technical assistance program to implement the CARA amendments to CAPTA, but also to get, as I mentioned a few minutes ago, to address all the potential intervention points for women and families affected by substance use disorder, including universal prevention, as well as addressing women of childbearing age and pregnant women in identifying, screening, and making those linkages to treatment. And so if you have any questions about the work of ACOG or even how to engage, perhaps you may not have a state office for ACOG or a district office, but more than likely there is a practitioner in your state that is involved with the national office of ACOG and maybe a state representative, even though there might not be a state office as we find here in New York. So with that, I want to again thank Kathleen, Dr. Gary, and Kelly for presenting today's webinar. I want to thank all of you for your time today and joining us. And we look forward to our continued work together. And feel free to follow up with any questions or any other assistance that we may offer through the National Center on Substance Abuse and Child Welfare as you look to strengthen services to families, infants, families, and children affected by substance use disorders. Thank you.
Thank you.
Thank you. Thanks. Thank you.
Thank you.